Good afternoon, everyone. Thank you so much for joining us today. I'm Dana Parsons, Vice President and Legislative Counsel with Leading Age Virginia, and pleased to have you join our member call. Thank you for taking time out of your day. We're pleased to be able to provide you today with an update on the CMS nursing home staffing proposed mandate, and then a bit of an update about where we stand on this issue in Virginia, along with a couple of budget updates. So we are so happy to have Janine Fink Boyle join us today, Vice President of Health Policy and Regulatory Affairs with Leading Age. And then Tim Fate, with Vice President of Information and Health Analytics with Leading Age New York, is here to talk with us about a tool that they have developed that shows the impact on states, including Virginia, if this rule were to be passed. So with that said, over to you, Janine. Thanks for being with us.
Thanks, Dana. Good afternoon, everybody in Virginia. Happy Thursday, almost the end of the week. Great. It's been a long couple weeks. I know it's been a long couple years, but we are at the beginning of the end, I guess is what I could say. We know that there has been a microscope on nursing homes, been under the microscope, I should say, in lots of different parts and components of your organization, whether it had to do with COVID, whether it had to do with reimbursement, whether it had to do with particular regulations, but all swirling around that has always been the focus on staffing. And we know that through the current administration that there has been a push on accountability and transparency. But the other big piece that we heard in the State of the Union in the last 2 years has been looking at a mandate for staffing in nursing homes. What was undertaken by the administration was to make some decisions on what that staffing mandate could be, what that staffing mandate could be, implementation timeframe. And what we know is that what was asked of CMS was to have a study that was to be completed in the past year. Prior to that, there has been some research and data gathered through what you submit in the payroll-based journal. There's also data that's been looked at through MDS and cost reports. And then as well as we went through fiscal year 23 with the SNF PPS rule, there was a request for information, 17 questions in there, specifically focused on staffing. And so with all of that together, CMS then contracted with a company called Apt Associates. And they spent the last year or so, give or take, actually performing a study that had both qualitative and quantitative analysis to it. They did a literature review. There were stakeholder sessions that were held in June of 2022. There were site visits between September and November of 2022, and there were about a little bit over 360 nursing home staff and residents and family members that were interviewed in 31 nursing homes. They were also looking at listening sessions from individual stakeholders as well, and also associations. Leading Age was one of those associations that were part of the stakeholder listening sessions. And then again, as I said, looking at the payroll-based journal, looking at Nursing Home Compare and the quality measures, the safety measures, and there were also simulated time studies that were done in delay in omitted clinical care and analysis of state requirements, as well as looking at your survey report. So both for annual and for complaint surveys, and looking really at the CASPER system. So all of that together created this multifaceted approach, which then dropped what we now know as a proposed staffing mandate. So a rule was released on September 1st, the Friday before Labor Day, and then published in the Federal Register on September 6th. And it's important for those dates, and we're going to talk about why. You need to have those dates in mind. So with the publishing in the Federal Register, it is about a 230-page rule. It outlines 3 specific parts. Now, again, I cannot stress enough that this is a proposed rule, which means, and I know that you've heard this, but I do need to keep hammering it home, is that it's not on the books as a final rule. It is not that you need to get off this call and go and implement the parts I'm going to talk about. It is a proposed rule, which allows us to have a 60-day comment period. And this is where the dates come into play. So as it was published on on September 6th, we have 60 days to comment back to CMS, which is the comments are due on November 6th. And just like Leading Age has done in the past with the PPS rule, with home health rules and hospice rules, we take this time to have sessions like this with all of you in different state partners. We have town halls where we're trying to do some presentations, but then get input from all of you in our nursing home networks so that we can craft and draft our comments, work on our advocacy and our education lines of action items, as well as help you then craft and draft comments, because every comment that is submitted to CMS by November 6th has to be read and analyzed. And that's all part of the process to get to the final rule. So although we have 60 days to get those in, there's no timeline on the backside then for CMS to make the rule final. But the comments that we submit can make changes. We saw that in the PPS rule between 2022, 2023, and then with the final, what came out in 2024 with fiscal years. And so it makes a difference. And if anything you walk away from today, you should walk away with the fact that you and your organization are going to submit comments. You're going to help staff submit comments, your families, your residents, and your organization as a whole. And we're here to help you. Jody and I are here to help you do that. So let's just talk about the rule. There are three main parts to it. That has an RN component, an hours per resident day component, and then enhancement to the facility assessment, which should not be any surprise to you when we say the word facility assessment. There's a staggered implementation that really focuses on rural and urban, and I'm going to go in these in more detail, but I'm just going to do the overview. There are time limited exemptions, or what we'll know, as a waiver, and then there's exceptions to be able to apply for those that particular waiver. When you dig down in the rule, it really focuses in on the needs of nurses, looking at how many are needed for 24-hour, 7-day-a-week RN, which is one of the three parts, and those hour per resident day for both nursing assistants, nurse aides, and registered nurses. Notice I did not say LPN or LVN, and we'll talk about that. The other part of the proposed rule has $75 million that will go to HRSA for a national campaign of education and training. So that would be grants to help move individuals into the long-term care sector for training. It could also be used for helping LPNs and LVNs become registered nurses. That's separate and apart. The actual mechanisms on how that will work have not been outlined yet, but we do understand right from CMS that campaign is earmarked for long-term care. Now, there is also another $100 million that's out there for long-term services and supports training, which we know that long-term care can tap into, but it's not specifically earmarked like the $75 million. The last part of the proposed rule then focuses on Medicaid payment transparency reporting, which for all of you actually really is the onus is of your state survey agency, that they will need to be reporting to CMS on nursing homes, direct care cost and compensation that of your Medicaid dollars. And then that will in turn be put on the public space, which we know as Nursing Home Compare. But as we've been looking at this part of the proposed rule, we know that it comes back to the nursing homes that will have to feed this information to state survey agencies. And we have some concerns about that accuracy of that data and what it will actually be used for. And then as I started with, I'm going to end with in the overview is the comment period. Again, 60 days where you can make comments on all parts of the proposed rule or the rule as a whole. But what's important in this rule is the outline that I just went through for the proposed staffing mandate. There is one ask in there, and there's actually two asks, but one of the first ask is to have an organization, an association, an individual comment on a ratio of 3.48. Now, in the proposed rule, the hours per resident day are broken out to RN for 0.55 and nursing assistant for 2.45. But they're not using the total hours of 3.0. They're very specific in the rule about those hours per resident day, and one can't overlap to use the other. In the rule, they're asking for the total nurse hours. If it were to be at 3.48, how could your organization meet that, or what challenges would you have? So that's an ask in the rule also. The other ask is looking at some of the administrative staff and using them in the
Do we want to let them do it?
and so with that, that's another ask. So your comments not just are on the overall proposed rule, but they're also on these other pieces, sort of like what they did in the PPS proposed rule with the RFI for staffing. And so it gives the opportunity to really give more depth to your organization and what we see as how you use LPNs and LVNs, how there could be some more challenges if that particular ratio were to go to 3.48. So next slide, please. So let's talk a little bit about the 24/7 RN requirement. What it is in the proposed rule is to focus on the fact that you currently have the federal requirement, which you're supposed to have an RN in your organization 8 hours a day for 7 days a week. This changes it now to you should have an RN in your organization 24 hours a day, 7 days a week. And with that, they will be able to provide direct care. We still have some questions on who will be part of it. We assume from the way that it's read in the proposed rule that the DON would be part of this. However, we've had questions that we're trying to filter out. Well, what about your ADON or infection control or MDS or staffing coordinator if they're RNs? Larger buildings have more people that fulfill those roles. We know smaller buildings, people wear different hats. We don't have an answer for that yet. As it says, the DON hours would count, and we're soliciting feedback on that. And that's what I had talked about along with the 3.48. Now, you know, there is an existing waiver process, and we know that we do have members that actually do have a waiver. That waiver will stay into place. You can still apply for that waiver, but it would be for the 24 hours a day, 7 days a week nurse requirement, which is in this proposed rule. And so with that, there's an implementation, and this is where some of the staggering starts. So implementation of this rule when it becomes final. And again, we don't have a final date. We don't have a final rule. So when it becomes final, implementation for the 24/7 RN for urban organizations is 2 years. And this is based on the Census Bureau definition of urban and rural, because rural has 3 years from the final rule. And that rural includes population, housing, and territory that's not located within an urban area. So if you are considered rural, then you would have 3 years from the final date in order to implement and be compliant with 24/7 already.
He was on hospice care, so if they brought that stuff in, and is it still here somewhere and just needs to be coming picked up?
Oh, okay. And I was like, answer for that. Okay. Second part of the proposed rule has to do with the minimums, the minimum RN and nurse aid hours per resident day. And so, as I said before, what they've broken it out is into RN, so registered nurse, does not include LPN or LVN, and nurse aid, so your certified nursing assistants. And again, we've had some questions regarding med techs, or I know some states have different names for certified nursing assistants that might have different roles. They might not be part of the PBJ job codes, and that's what we're trying to ask, like how that will fall into place. But what we know as you as a certified nursing assistant and you have a registered nurse, that's what's here. 0.55 for RN and 2.45 for nurse aid. I'm going to skip a little bit around in on the slide. I'll get to all the pieces, but just so that you know, what I really want to focus in on first is the minimum part. So the minimum means this is, and you can see it through the rule, this is the floor, right? This is what your organization needs to have to be compliant and meet this requirement, to meet the rule. We expect that either the federal tag for sufficient staffing will be changed, or there could be a new F tag. Again, that's not spelled out in the rule, and CMS won't say to us, oh, we're going to have 6 more F six more F tags. We don't know that. But what we do know is that this is the minimum. And so what's important for you for that is that they are going to stress that your organization is unique, right? Your organization has different types of residents that you provide services for. So again, thinking about the acuity, thinking about the services that you provide. So whether you have bariatric residents or you have residents that have trachs or on ventilators, the different acuity that the levels might be higher on one unit than another. Thinking about dementia and Alzheimer's, looking at behavioral residents or substance abuse, you might need to have a different staffing ratio, and it should be higher. What we do know is that the survey teams, that's how they will be coming when they come in your organizations now for annual survey or on a complaint. They'll be looking at facility reported incidents. They'll be looking at accidents or anything that happens to residents. Again, if it causes harm or immediate jeopardy, and then obviously going back to your staffing. They'll be reviewing your PBJ data before they come in and trying to get an idea of what, as I said, what they do now. But again, if there's any need for higher staffing because of higher acuity, you potentially could fall into non-compliance. And so with this, there is the ability to have an exemption. So we have what we just talked about, the waiver for the registered nurse for 24 hours, 7 days a week. But there's an exemption for the minimum staffing standards. And so it seems a little complicated, but kind of when I walk through it, I think I'm hoping that you'll understand. So you can request an exemption if you meet these 3 particular standards, right? So the first is based on the location. The second is that you have good faith efforts to recruit and retain staff. And that means that you're actually documenting, you have a plan, you have a process, you're able to show that. And then with that, you have financial commitment, and that's a documentation. So whether it's a budget or you're showing invoices. And so that's part of what you need to have, the 3 pieces for an exemption. Now, let me talk about the location. It's very specific, and I'm going to read it. It says that providers must either be located in an area with a medium, which is 20% below the national average, or low, which is 40% below the national average, provider population ratio for nursing workforce. That's determined by CMS, and they're basing it on the data from the Bureau of Labor Statistics or Census Bureau. One part. Or, again with location, you'd be located 20 miles or more from the next closest long-term care facility as determined by CMS. So you have to meet one of the 2 pieces of location, you have to have the good faith effort, and you have to have the financial commitment. You can then apply for this time-limited exemption, time-limited waiver. They're effective and good for 1 year, and they're eligible to be renewed. Now, how you can not apply for it, there are criteria. So in this particular case, if your organization has not been submitting to PBJ and you're non-compliant, and we know that is obviously something that you need to do through your PBJ system, and you have a mark against you for that, which obviously also brings your star rating down. You are a special focus facility, or you have this insufficient staffing F tag that we know is out there, and you've shown a pattern, or you've been widespread, you've had harm, or you've had an immediate jeopardy for insufficient staffing within the past 12 months. If you had any of those, it doesn't have to be all of them, it's just one of them, then you cannot apply for the exemption. All right, so 24-hour, 7-day-a-week RN has the RN waiver, and the minimum RN and nurse aid staffing has exemptions, but then they have the eligibility requirements. So this again has a staggered implementation. So when the rule becomes final, the implementation is 3 years for urban facilities to be compliant and 5 years for rural. All right, next slide. So I think I covered a little bit of this as I was talking. We know that the way that survey teams will come in and enforce the minimum staffing standards will be through survey and certification. They go back for PBJ data, and looking for your PBJ data. And, subject to remedies and penalties, we always put this on here because your enforcement, we don't know what they will be. We don't know if it'll be an immediate fine. We don't know if, there'll be any sort of, denial of payment. I don't know what that kind of trajectory would be. With the waiver, you cannot use the minimum staff. If you meet that, what we just talked about with the exemptions, if you meet that, it doesn't mean that it follows through for the 24 hours, 7-day-a-week RN and vice versa with that. So they're completely separate ones that you have to apply for. And next slide, please. So just a little bit of impact, and this comes right from the rule. What CMS has done, they kind of took the average of cost of RNs throughout the country. And then there's data, and Tim's going to go through some, great Excel spreadsheets that you can use in your organization. But the impact in order to meet the 24/7 RN, what's on the books right now is just over 3,000 additional RNs, so 3,267 to be exact. And that's $349 million a year. And the reason that, Jody and I actually pulled this out along with the impact for the hours per resident day, because you're looking at almost 13,000 RNs. So add that into the already 3,000, you're almost 17,000 RNs. But the nursing assistants is where there's a huge number, 76,376, $4.2 billion a year. It is a large amount of dollars that are needed to get these individuals into your organizations to meet the minimum staffing mandate. And with that, what I will say is that how does that equate to only $75 million for training? Where's the pipeline going to come from? We know there needs to be reform in immigration. We need schools that have closed to reopen. We need training sites. That I don't know if $75 million is going to even be a drop in the bucket compared to what is needed in the staffing and the cost impact. And that's right from the rule. So CMS knows exactly what it's going to take, but we just don't know where that's going to come from. So the next slide, please. The last piece of the staffing mandate is facility assessment. And so as your organization became compliant with ROPES phase 2, you have your facility assessment. And we've heard from lots of organizations throughout the country over the past few years that surveyors look at facility assessments in different ways. However, in this proposed mandate, it is now going to be enhanced. And with the enhancement for the facility assessment, they're focusing really on evidence-based and data-driven, really trying to look into the importance of having the right staff, taking care of the residents that you're serving, the services that they need, the equipment that is needed, and making sure that what is in that facility assessment, that you're carrying it out in the organization. And so that's to help you actually determine your appropriate staffing. With the development and implementing a facility assessment, they want to then, and this is right from the rule, have staff or representatives be part of that. So it's not just your leadership. You're looking at having management and direct care staff as part of the planning process to create the facility assessment. You're looking at care plans and other resident acuity tools. So again, driving those staffing decisions. They have a focus on behavioral health issues. So if you're taking residents that by history have behavioral health issues, are you then making sure that you're staffing accordingly so there aren't any sort of incidents and accidents or challenges within your resident population. Again, the facility assessment is there to inform decisions and ensure sufficient staffing. The other sections in the enhancement are to make sure that you have all shifts and weekends included in the facility assessment, as also with a contingency plan and emergency planning in circumstances that it doesn't activate the emergency plan. So what are you doing if you need to there's a certain emergency and you have your contingency plan? So in the case of a pandemic, right? I'm just going to put that out there. And then there's a plan for recruitment and retention. So let's go back to how you would be applying for an exemption. You should have a recruitment and a retention plan in good faith. That should be part of your facility assessment. And this is number one. So this is the first compliance date that you have when that rule becomes final, the implementation date, there's no rural and urban change. Every nursing home, all 15,000 nursing homes in the country have to be in compliance 60 days from the final. Next slide. The last piece is the Medicaid payment transparency. And as I said before, this is really proposing requirements for state Medicaid agencies. And they're looking for those states to then report out the percentage of Medicaid payments that are spent on the compensation of direct care staff and support staff in their organizations. And so with that, we're saying that that needs to come obviously from the nursing homes, but once it's reported to the state and they report it out, then they're going to report it to CMS, and then it will be Nursing Home Compare. We do have concerns, as I said, providers will then have to report another administrative burden. And then, will there actually be some inaccurate conclusions on it? Really opportunities is that what will be shown that's out there, and that's the dollars that are supposedly used, but your organization also might have other parts in there, and there could use those Medicaid payments for other benefits of residents. And so there's a lot of concern that we have about this. Although it's a small piece of the proposed rule, it will be part of our comments. So the overall concerns that we have with the proposed rule, I think is what that we've always had, right? There's not enough people. There's not enough people, currently to fulfill the baby boomers that are coming that will need nursing home services. But in order to fulfill what we just saw at 13,000 and 3,000 and 76,000, where are those nurses and nurse aides going to come from, either domestically or internationally? We know that registered nurses when someone becomes licensed, don't always choose long-term care as their service provider to work in. And they go to a hospital, or they come and get their feet wet in long-term care and then go over to a hospital, or maybe working in consulting or some outside agency. I will say for us as the continuum of care, we're concerned about, we already know there's shortages in home health and hospice care. And so we're just going to be fighting for the same pool of people. And how is any organization going to survive? The reimbursement, again, it's $40.6 billion in order to implement this proposed rule. So adding everything up together, that number comes right from the rule. And that's over 10 years. There's no money. It's an unfunded mandate. And so with that, it's very clear that it's supposed to come from the payers. And so without increases in reimbursement, which we know some states have increased Medicaid, they're not concerned about Medicare, because we know that that system has had an overall overhaul. But again, if we need to pay people more dollars, we're just using that in the labor pool, and then your organization maybe isn't able to do some capital improvements. The additional reporting burden for providers, as we talked about the Medicaid transparency, but we also know that enhancement to the facility assessment is going to cause some concern with time and labor. We do feel, and when I talked about the study and the work that was put together for CMS to come to the proposed rule, what I did leave out is the rush that we saw. If you were following, so before the Labor Day weekend, about a week or so before, the actual study from ACT Associates was posted on the CMS website. It was then found, a reporter found it and linked to it and did a news report on it. When we went to go look for it, it was then taken off. And what then came out from CMS is that was a draft report. And so we believe, where others do too, that it was leaked. And with that leak, they actually had to rush to get the proposed rule out. And we say that because with the proposed rule, it's been sitting and waiting at OMB in this, status since, May. And OMB then allows associations and organizations to have meetings where you have 30 minutes to basically state your case why a rule that you don't even know what the specifics are of the rule, but why a potential mandate could cause problems. And so Leading Age had a meeting at the end of June with OMB. We were one of many associations that had meetings. We do know there were 2 more meetings that were on the book for September, but when this staffing survey, the data, the study was leaked. Those meetings were canceled from OMB, and then the rule was removed, which then we knew it was going into status to drop in the Federal Register. And that happened within about a week to 10 days before September 1st. So we feel that, there was a lot of rush on it, that there really, when you go back and you look at the study, which was 600 pages, what's in that study talks about quality and safety, completely dismisses LPNs and LVNs, really just focuses on RNs and nursing assistants. And there's really no evidence in there to show what has been going on, even with all of their qualitative and quantitative analysis. The other part was a lack of transparency. There was never really anything other. There was a couple listening sessions. And so we think that there was a lot of miscommunication and a rush to put the rule out. And when you actually go back to the study, as we've seen from some media outlets, the consumer groups are not happy. They wanted a higher hours per resident day. A lot of organizations, I think, what we know through Leading Age can meet what's in there, but there's still going to be some adjustments, and where again are you going to find the staff for that? And so next slide, please. So what are we working on? So we're working on a few different areas. Education is one of them. So we had a town hall last week. We're working with our state execs. You will see in the next day, we have another town hall next week. It's on September 21st, where we have some members that have staffing mandates currently in their states. And they're going to talk about how they have worked to meet the staffing mandate, and then what they see for the future with the federal staffing mandate. We'll also go over the rule a little bit again. We are working on specific nursing home network meetings. One's on September 26th at 2 p.m. Eastern, and then the other one is on October 5th that Jody will be leading. And those meetings will be able to have the kind of voice and talk a lot about the rule itself in order to put the comments together. We'll have draft comments by probably the second week of October, so that you could use those if you want, or parts of it. On the advocacy side, we are really looking at, Dana, will you go back for 1 second to the slide, right? On the advocacy side, we're really looking at how can this be proposed rule be implemented? And we know that there are two key areas that need to be fixed, which is reimbursement and have adequate funding, and then obviously have the qualified applicants or have the staff that are needed for it. And so we're really focusing in on asking for the rule to be withdrawn. Next slide, please. We're working obviously on the Hill side, because although all those comments will go to CMS, we know that pressure from Congress could try to make some adjustments. And so we're working with Senate Aging, Senate Finance, House committees that specifically could have jurisdiction over CMS and over obviously labor and HR and HRSA. We also ask all of you, if you did the congressional visits during Congress in your neighborhood over the summer, when Congress was back in your communities. I know that they're back here in DC, and obviously there's a big looming deadline ahead with the government potentially shutting down. But although when the comment period ends, we still have the ability to keep our voice active, and hopefully the government will not be shut down, and we can and they can focus more on our particular issues here. As we talked about the nursing home network, we also want to use the full continuum, as I talked about home health and hospice, and the concerns that they have there, and to speak with our one voice. And then we're trying to work with other associations. So the American Hospital Association, the Rural Hospital Association, nursing associations. We just got an ask from the Pharmacist Association, and really try to work together to have that one voice. I think probably who will not be collaborating with will be the consumer groups. They have a different outlook than we do on the workforce and the reimbursement. And so I think that is the end of my presentation. And in here is great. Please use our website. I know that our website, we have I just did an FAQ yesterday that's got posted up there, but you can link to the rule, you can link to this amazing analysis, and I say that because I just think that Jody is amazing, that she put together, which kind of goes over in detail a little bit more than what I just did. And so with that, there's also the CMS fact sheet I think is helpful. And then it links to the study. So if you're, want some like nighttime reading, the 600-page study you could read through, which is the rule is based on. So that's all I have, Dana.
Thank you, Janine. Thank you so much for that really comprehensive overview and for your advocacy. In the chat box, we've included a link to the resource on Leading Age National's website for all the resources that Janine just mentioned. And the nursing home network that she also mentioned is a really great network to belong to get up to date on all the federal issues. So we put that in the chat as well. So now we're going to transition over to Tim with Leading Age New York to talk about a tool that demonstrates the impact on all states, including Virginia. And I'm going to put a link in the chat box that you can link directly to this Excel spreadsheet that he has put on the web on the Zoom now. But over to you, Tim. Thank you.
All right. Hi, everyone. So my name is Tim Tate. It looks like Fate, but the H is silent. I'm with Leading Age New York. I'm happy to be here. So when the proposed regulation was released, we quickly started looking at the tools that we have available to members, and those being quality metrics, the 5-star report, and the skilled nursing facility trend report. And all of those tools are used to for members to be able to see how they're doing compared to their peers. And so whenever you compare one organization to another in terms of staffing, you use your the case mix adjusted numbers. So unfortunately, we didn't have any of the just plain reported numbers that come straight out of PBJ in any of those tools. So what I'm going to show you is sort of our quick kind of let's get something in members' hands solution. We will be working on something better that's more geared towards an individual provider later, but that's coming. So you can download this this file from the Leading Age website. I think Dana she put it up already. Perfect. So you will need to log in to the Leading Age website for that, as it's a members only tool. We built this file so that it could serve really two different purposes. One, it would be helpful to you as a member. And then secondly, that it would be helpful for people like me at the state affiliate level to see how things go in our state as a whole, and then also Leading Age to be able to see how things look from even a higher bird's eye view as the whole country. So the first worksheet in this Excel file is the SNF detail tab, and this has all of the nursing homes that are in Care Compare right now. It is ordered by state first, and then by provider name. So if you want to find your provider row, you can either use just scroll down to your state and then look for your name. The other option is you can click on this find and select button, and click find. Let me bring the window over here. Let's see, I'll type in pond, and you can click on find next, and it will find provider names that have pond. So this one's in Colorado, and I can keep clicking. Now we're in Iowa and Indiana. So you can use that to find your nursing home name, and then from there, then you can scroll over to the right, which I'll show you now. So let's pick this nursing home right here. So you can see that this is a rural nursing home, and we added information in the sheet that was pertains to the proposed rule. So the timelines of things, if you're urban or rural, there may be different timeline that's allowed. We have the number of beds, just because I think that's good context for looking at staffing needs. We have the special focus facility status and the abuse icon status as well. So the next few columns are the reported hours per resident day. Now, this is based on the PBJ data, but these three numbers, we included RN, AID, and LPN. We included LPN just so that it gave a bigger picture of the context of the nurse staffing. Although, again, the standards that Janine was talking about only included RNs and aides. So it's really these first two that are pertinent. And again, this is really a quarterly average. This is not a daily. So this kind of gives you just a big picture view of whether this facility meets the requirements. So they're at 1.02 for RN hours per day. So this is what this field here, the RN status, they meet the requirement. Now, again, this is based on a quarterly average. But you can see their AID hours is 2.3, which is under the 2.45 minimum. So they didn't meet that requirement at a quarterly average. The next two columns are to just give sort of a high level idea of how much they would need to increase staffing to meet that minimum standard. And since they met the RN standard at the quarterly average, they don't need to increase their RN staffing to meet that standard. They would need to increase their AID hours by 5.7% so that they could get this 2.3 up to the 2.45 hours. Okay, so again, these columns from column K over to the AID increase, those are all based on those quarterly average numbers. Now that a week has gone by since I built this, I'm considering removing all of those columns right there and sticking more to the next set of columns. So I'll go over those next. So the reason why is that, again, the other hours, the other columns are based on this quarterly average. And now what the next few columns are focusing on are individual days. So the count of days with residents, this is based on 2023 Q1 numbers. So there are 90 days in that quarter. And for this facility, they had 90 days where they had residents. There are some facilities in the country that, for whatever reason, they only had 30 days in the quarter where they actually had residents. So we only want to calculate our numbers based on the days where they had residents in their facilities. So even though at the average, quarterly average, this facility met the RN requirement, there still were 16 days during the quarter where they did not meet that 0.55 RN hours per resident day. And there were 53 days in the quarter where they didn't meet the 2.458 hours. So, and then this is just the percentage of days where they're not meeting the RN minimum standard. So 17.8% of the days for RNs and 58.9% of the days for aides. So that is that is what we have right now. I will tell you, I have been working all morning on this. What I'm trying to do now is add to this analysis the financial impact. And so CMS in their the proposed rule, they discuss using the Medicare cost data for nursing homes from fiscal year 2021 to project out their costs. And so I am working on trying to repeat their calculations. And to do that, I'm figuring out, okay, so based on these days right here, where, you know, this facility had 11 days where they didn't meet the RN requirements, how many hours would of RNs would have been needed for them to meet that minimum standard? And then based on that, how much would that cost that facility to have met that requirement in that quarter? So stay tuned to that. I would just keep an eye out for the leading age emails and such. Once that gets all worked out, I'm sure it will be released to you all then. But just stay tuned. We're going to try to have some sort of financial impact analysis here that each facility can look at. So hopefully that comes up soon. All right, so the next tab in the spreadsheet are the state level aggregates. Currently, this is based on those quarterly numbers that I was showing you where a facility met or did not meet the requirement. Again, this is sort of think of this as more of the quarterly average as sort of a bird's eye view of a provider. And then this is sort of the even higher bird's eye view kind of at the state and national level of those quarterly averages. So you can see the top row has has USA listed. So in our data here, we have roughly 15,000 nursing homes, and of those 49% or almost 50% have met the RN requirement, whereas 47.6 have not. We do have some facilities that have missing data. They are listed in Care Compare, but they do not have PBJ data for Q1 of 23. So each of the blocks here, this is the ownership type. So this represents all facilities. The green block here represents the for-profit skilled nursing facilities. We have the government and the nonprofit. So, you can scroll down and there's Virginia right there. So you can see how Virginia compares to the US as a whole. And you can also then see how the nonprofits in Virginia are doing compared to the other groups. So as you would expect, Virginia is the nonprofits in Virginia are meeting 72% of them are meeting the requirements for the RN minimum standard, again, using the quarterly average. And you can look to see that the government and the for-profits are not doing as well. So use this however you want, but the purpose of it is to give the state affiliates and the national sort of a big picture of how each state is doing based on those ownership groups. So again, just stay tuned. I will I'm gonna have some new data coming up here soon, but I need to do a little bit more work and have several other eyes look at it and make sure what I'm putting out is helpful and accurate. So that's all I have.
Thanks, Tim. We really appreciate that. We appreciate all the tools that Leading Age New York provides and appreciate being able to see the breakdown, the not-for-profit government versus for-profit. So we know you have to hop off for another commitment, but thank you for being with us today.
My pleasure.
Hey, so thank you all. Want to just kind of switch gears for a moment and talk about the status of staffing standards here in Virginia. So during this last General Assembly session, legislation was passed establishing a staffing standard for every CMS certified nursing home that's eligible to participate in Medicaid. And that would be to provide at least 3.08 hours of case mix adjusted total nurse staffing hours per resident per day. So this legislation is not gone into effect. It has a delayed effective date of July 1st of 2025. It is narrowed that it only applies to nursing homes that are participating in Medicaid. The legislation also included a provision that if a federal staffing standard is established, that the Virginia staffing standard would be repealed. So that's a little bit about that. And quickly, just to give you an update, our budget, which was long overdue in Virginia, was recently approved. We have $7.3 million that's been allocated to the auxiliary grant for assisted living to increase it from $1,609 to $2,055 per month. We were advocating for $2,500, which was a recommendation of the Joint Commission on Healthcare, still not enough. We're pleased that an increase was passed, but we'll continue to advocate for a higher rate. $9.5 million has been allocated for workforce initiatives to really help the nursing staffing health work shortages as well as behavioral health. And then we had some time ago an increase on a temporary basis for the Medicaid adult day rate to be increased to 12.5%. That increase is a temporary increase. Of course, we're continually advocating for a permanent one. That extends through June 30th of 2024. The General Assembly did have the option of pulling that provision out. They did not, so that's good news that that was preserved. So appreciate the opportunity to give you all kind of a highlight of what's happening in Virginia. I will comment, I see in the chat box that there's some difficulty with accessing a link to Leading Age National. I'm not sure what's going on with that. I'm sorry about that. It will be in our newsletter and in our update that we send you with the link to today's recording. So that's all I have. Appreciate everyone's time today. Didn't see any specific questions come in the chat box. But if there are questions, but actually, Paul is just going to give you a quick overview of some of our upcoming education.
Thanks, Dana. I just wanted to say our Educate and Engage newsletter is coming out on Monday morning. It lists all of these as well as a lot of other educational opportunities that are coming up. It affects everybody, so take a look at it when it comes. National has some, other states have some. We have a lot of education coming up. A lot of these do have the NAVCEs that y'all request all the time. So just take a look at these and then check out the Educate and Engage newsletter when it comes out on Monday morning at 8:30.
Thanks, Paula. Well, thank you everyone for your time today. We do have time for some questions if you have any, or if you want to get some time back in your day, I'm happy to give you 7 minutes back. You do have my email address if you'd also like to email. Okay, well, thank you all for your time today, and we'll be following up with the recording.